السلام عليكم ورحمة الله وبركاته. أعزائي طلبة طب الاسنان المرحلة الخامسة، أحييكم ويسعدني أن أتواصل معكم في سلسلة محاضرات مادة طب الفم، إن شاء الله تستفادون من عندها. نبدي بسم الله الرحمن الرحيم محاضرتنا الأولى واللي تحمل عنوان Pigmented lesions of oral mucosa. بالبداية عندنا we have two sources of oral pigmentation, exogenous source and endogenous source. Common causes of endogenous oral and perioral discoloration include vascular extravasated hemorrhage, hemosiderin, melanin, bilirubin. The endogenous source of pigmentation include metal, graphic ink, bacteria, drug complexes, and plant derivatives. The endogenous pigmentation, the important and most common source of endogenous pigmentation in the body is melanin. What is melanin? Melanin is the pigmented derivative of tyrosine and is synthesized by melanocytes, which typically reside in the basal cell layer of the epithelium. Their presence in the skin is thought to protect against the damaging effects of actinic radiations, as well as to act as scavengers in protecting against various cytotoxic intermediates. The role of melanocytes in the oral epithelium is not clear. Overproduction of melanin may be caused by a variety of mechanisms, the most common of which is related to increased sun exposure. Intraorally, hyperpigmentation is more commonly a consequence of physiologic or idiopathic source, neoplasia, medication, or oral contraceptive use. High serum concentration of pituitary, adrenocorticotropic hormone, post-inflammatory changes, and genetic or autoimmune disease. Focal melanocytic pigmentation. We have the first lesion called freckle or ephilus, commonly occurring asymptomatic, small, range from 1 to 3 mm, were circumscribed, tan or brown colored macule that is often seen on the sun-exposed regions of the facial and perioral skin. Developmental in origin, tend to become darker during period of prolonged sun exposure, thus to say during spring and summer, and less intense during the autumn and winter months. No therapeutic intervention is required. As we see in this picture, this lesion is only found on the skin, not present in the oral mucosa, rarely seen in the oral mucosa, just seen in the skin of the face, as we see in this picture, appear as a small spot, macular eruption with brown color. The second lesion is called oral labial melanotic macule. Is unique benign pigmented lesion that has no non-dermal counterpart, just in the oral mucosa. Trauma has been postulated to play a role, develop more frequently in females, usually in the lower lip, site of predilection, and gingiva. However, any mucosal sites may be affected. Small, less than 1 cm in size, well circumscribed, over or irregular in outline, and often uniformly pigmented. As we see in the picture, irregular, this picture reveals the melanotic macule in the lower lip, female. الكلر مثل ما هو واضح, brown or to black in color, with regular border, oval in shape. Once the lesion reaches a certain size, it does not tend to enlarge further. Unlike an ephilus, a melanotic macule does not become darker with continued sun exposure. هاي حتى نفرق بينها وبين الليجن اللي حكيناها بالبداية, الفريكلز أو الإفيلس اللي كانت يزيد الانتنسيتي مال الكلر مالتها with sun exposure. This lesion does not generally recur following surgical removal. The other lesion is oral melanoacanthoma, considered as unusual, benign, melanotic lesion that is unique to the mucosal tissues. Most patients report a rapid onset and acute trauma or a history of chronic irritation usually presents the development of the lesion. Asymptomatic, although pain has been reported, although any mucosal surface may be involved, the buccal mucosa is the most common site of occurrence. This lesion show the lesion as we see in the buccal mucosa, and as we say, the lesion is confined only to the oral mucosa, not seen in the skin. The size of the lesion is variable, ranging from small and localized to large diffuse areas of involvement, measuring several centimeters in diameter. The borders are typically irregular in appearance and the pigmentation may or may not be uniform. A biopsy is always warranted to confirm the diagnosis, but once established, no further treatment is required. The other lesion is melanocytic nevus, arise as a consequence of melanocytic growth and proliferation. Genetic and environmental factors are thought to play a role in the nevogenesis. Oral melanocytic nevi are rare, typically present as solitary lesions, and may be more common in females, and have no distinguishing clinical characteristics. Lesions are usually asymptomatic and often present as a small, less than 1 centimeter, solitary, brown or blue, well circumscribed nodule or macule. Oral nevi may be developed at any age. However, most are identified in patients over the age of 30. The hard palate represents the most common site, followed by the buccal and labial mucosa and gingiva. The common blue nevus is characterized by an intramucosal proliferation of pigment-laden spindle-shaped melanocytes. The melanocytes may reside deep in the connective tissue, and the overlying blood vessels often dampen the brown coloration of melanin, which may yield a blue tint. Biopsy is necessary for diagnosis. As we see in the picture, in the pointed area, this is melanocytic nevus. And as we say, the biopsy is very important. Biopsy is necessary for diagnostic confirmation of an oral melanocytic nevus, since the clinical diagnosis include a variety of other focally pigmented lesions, including malignant melanoma. Complete but conservative surgical excision is the treatment of choice for oral lesions. Malignant melanoma, considered as the least common but most deadly of all primary skin cancers. Similar to other malignancies, extrinsic and intrinsic factors play a role in the pathogenesis of melanoma. A history of multiple episodes of acute sun exposure, especially at a young age, immune suppression, the presence of multiple cutaneous nevi, and a family history of melanoma are known risk factors for the development of cutaneous melanoma. Oral melanoma may develop at any age, but most present over the age of 50. Any mucosal sites may be affected. However, the palate represents the single most common site of involvement. The maxillary gingiva is the second most common site. Oral melanomas has no distinctive clinical appearance. They may be macular, plug-like, or mass-forming, well circumscribed or irregular, and exhibit focal and diffuse areas of brown, blue, or black pigmentation. Up to 1/3 of oral melanomas may exhibit little or no clinical evidence of pigmentation, that's to say, a melanosis. Oral melanomas may present with what appear to be multifocal areas of pigmentation. This phenomenon is often explained by the fact that some tumors may exhibit both melanotic and amelanotic areas, ulceration, pain, tooth mobility, or spontaneous exfoliation, root resorption, bone loss, and paresthesia to anesthesia may be evident. However, in some patients, the tumors may be completely asymptomatic. Oral mucosal malignant melanoma is associated with a very poor prognosis. Regional lymphatic metastases are frequently identified and contribute to the poor survival rates. Less than 10% of patients with distant metastases survive after 5 years. As all this picture related to malignant melanoma, the first one, the upper one, in the gingiva, upper gingiva, appear as a black color lesion, irregular. And the other second picture in the palate appear as a swelling, and also in the third picture, the lesion appear in the upper labial mucosa. Multifocal diffuse pigmentation, the other type of pigmentation, we divide it to focal. حكينا على الفوكال، هسه نحكي على المultifocal أو diffuse pigmentation. The most common one and the most important one is physiologic pigmentation. Considered as the most common source of multifocal or diffuse oral mucosal pigmentation, dark complexion individuals including blacks, Asian, and South American frequently show patchy to generalized hyperpigmentation of the oral mucosal tissue. Although in many patients the pigment is restricted to the gingiva, melanosis of other mucosal surfaces is not uncommon. The picture shows physiologic pigmentation in the upper gingiva appear as irregular patch pigment. Drug-induced melanosis. The chief drugs implicated in drug-induced melanosis are the antimalarials, including chloroquine, hydroxychloroquine, quinine, and others. The pigment can be diffuse, yet localized to one mucosal surface, often the hard palate, or it can be multifocal and involve multiple surfaces. Some drugs may even be associated with a specific pattern of pigmentation. The picture shows discoloration in the tongue due to the drugs, mostly to mouthwashes, and appear as gray to brown in color, as we see. Much like other forms of diffuse pigmentation, the lesions are flat and without any evidence of nodularity or swelling. Sun exposure may exacerbate cutaneous drug-induced pigmentation. Smokers' melanosis. Diffuse melanosis of the anterior, facial, maxillary, and mandibular gingiva, buccal mucosa, lateral tongue, palate, and floor of the mouth is occasionally seen among cigarette smokers. The pigmented areas are brown, flat, and irregular. Some are even geographic or map-like in configuration. The picture reveals this type of pigmentation, that's to say, smokers' melanosis appear as brown to gray in color in the upper gingiva in heavy smoker individual. The other pigment pigmented lesion is post-inflammatory hyperpigmentation. It is a well-recognized phenomenon that tend to develop more commonly in dark complexion individuals. Most cases present as either focal or diffuse pigmentation in areas that were subjected to previous injury or inflammation. The acne-prone face is a relatively common site for this phenomenon. Oral pigmentation has also been described in patients with lichen planus. As we see in this picture, the patient has lichen planus in the buccal mucosa. We see the lesion and the Wickham's trial white color appear as white color, in addition to the presence of the pigment that is associated with the lesion and related to post-inflammation. The other lesion called melasma. Melasma is a relatively common acquired symmetric melanosis that typically develop on sun-exposed areas of the skin and frequently on the face. The forehead, cheek, upper lips, and chin are the most commonly affected areas. There is a distinct female predilection, and most cases arise in dark-skinned individuals. The term melasma is most appropriately used to describe the pigmentary changes associated with the pregnancy or ingestion of contraceptive hormones. This lady has melasma in forehead, appear as irregular pigmented lesion related to contraceptive drugs. The other lesion is melanosis associated with systemic or genetic diseases. We have the first one, adrenal insufficiency, or called Addison disease. Is a potentially life-threatening disease as much for its systemic complications as it is under diagnosis. A variety of etiologies may precipitate adrenal insufficiency, including autoimmune disease, infectious agent, neoplasia, trauma, certain medications, and iatrogenic causes. The end result is essentially the same, that is, a decrease in endogenous corticosteroid level. As steroid level decrease, there is a compensatory activation of ACTH secretion from the anterior pituitary gland. ACTH then acts on the adrenal cortex to stimulate steroid production, and ACTH secretion stops it. If low steroid level persists, there is a loss of feedback inhibition, resulting in persistent secretion of ACTH into the serum. Weakness, poorly defined fatigue, and depression are some of the typical presenting signs of illness. However, in some patients, the first sign of disease may be mucocutaneous hyperpigmentation, generalized bronzing of the skin, and diffuse but patchy melanosis of the oral mucosa are hallmarks of hypoadrenocortism. Any oral surface may be affected. In some patients, oral melanosis may be the first manifestation of their adrenal disease. The diagnosis of oral Addisonian pigmentation require a clinicopathologic correlation. Endocrinopathic disease should be suspected whenever oral melanosis is accompanied by cutaneous bronzing. Laboratory tests, including the evaluation of serum cortisol and electrolyte levels, are necessary to make a diagnosis of Addisonian hyperpigmentation. Serum cortisol level less than 100 nanomole per liter at 9 a.m. is a diagnostic of deficiency. Treatment consists of exogenous steroid replacement therapy. Thank you, and we hope to meet in the second part of the lecture إن شاء الله في المحاضرة القادمة نكمل الجزء الثاني منها، ونلتقيكم على بركة الله، والسلام عليكم ورحمة الله وبركاته.